Hello everyone, myself Shanaz and I welcome you all to my amazing channel Nurses, the Heart of Healthcare. If you are new to my channel, then please subscribe my channel Nurses, the Heart of Healthcare. If you are aspiring to become an ICU nurse, if you are interested to work in an ICU as an ICU nurse and worried about what type of questions you may face in an ICU nursing interview or what you have to prepare for an ICU nursing interview, then stay tuned as I assure you that this video will surely help you in preparing for ICU nursing interview. Because in this video I am going to discuss about 15 very frequently asked, very important and the basic ICU nursing questions and their answers with rationals. So let's get started. And before moving ahead, I would like to remind you all that whenever you're going for an interview as a staff, for a staff nurse or for an ICU nurse, whatever it might be, whenever you're going for an interview, look well and carry confidence and smile on your face. Confidence is very important. That has to be exhibited in your personality, in your voice and in your actions. Now let's get started with the question answers. The first basic ICU question that you can face is, what is GCS? Elaborate the components of GCS. Okay, so if you are working in an ICU or wanted to work in an ICU, we must know about GCS. What is GCS? GCS is nothing but Glasgow coma scale. It was named after the university in which it was developed by the neurosurgeons Graham Teasdale and Brian Jennett in 1974. Okay, so GCS is nothing but it's a clinical scale which was initially used to assess the level of consciousness in patients following the head injuries, but now it is widely used throughout the world in first aid and acute medical and trauma patients and the patients with significant brain injury. Okay, so GCS is very important, especially in neurology, in patients with brain injury. Okay, so GCS has been the gold standard of neurological assessment for trauma patients. Okay, so this is a tool, or we can say that this is a method of choice for trauma care. So GCS is used for people above the age of 2. Okay, for pediatrics below the age of 2 we have different pediatric GCS scale. Okay, so I hope I answered the question. So if they ask you what is GCS, then you have to answer this. Then the second part of the question was, elaborate the components of GCS. Like, what are the components of GCS? As you can see on the screen over there, the components of GCS. Okay, GCS composed of 3 tests. Okay, GCS composed of 3 tests, or we can say the 3 responses, that is the eye response or the ocular response, verbal or the oral response, and the motor response. Okay, altogether the total score of GCS is 15. Okay, minimum is 3 and maximum is 15. So the range is between 3 to 15. Okay, in eye response or the ocular response, the total score is 4. We give it as E4. And in verbal response or oral response, it is 5. We give it as V5. And in motor response, the total score is 6. We give it as V6. Okay, so the individual elements in each one is eye opening. The eye response we check for whether they open spontaneously or to speech or to pain or no response. Then next, verbal response, oriented to time, place or person, or confused or disoriented. Inappropriate words, then we give them 3. Incomprehensible sounds, we give them score of 2. And if there is no response, then 1. And when it comes to checking motor response, then if they obey commands, we give them 6. If they move to the localized pain, 5. Flexion withdraws from pain, then 4. Abnormal flexion, 3. Abnormal extension, 2. No response, 1. Okay, so the best score is 15. That means the person is fully conscious. And comatose patient, I mean if the patient is in coma, then the score will be 8 or less. Okay, or if the patient is totally unresponsive, the score will be 3. So these are the different components of GCS that you have to tell. I hope I answered the question. Then the next question that they may ask is, how frequently should we assess GCS in neuro patients? For this, you must first understand who are neuro patients. Neuro patients are those with neurological disorders or diseases of CNS or PNS. That means any patient with the disorders of the brain, spinal cord, cranial nerves, peripheral nerves, or the nerve roots, or autonomous nervous system, neuromuscular disorders, they are called neuro patients. Like for example, patient with epilepsy, brain tumors, stroke, Parkinson's disease, cerebral aneurysm, intracranial infection, brain abscess, multiple sclerosis, spinal cord injury patients, etc., etc. Okay, so all these are neurological patients. And how frequently we have to assess GCS in them? NICE, that stands for National Institute for Healthcare and Excellence. Okay, National Institute for Healthcare and Excellence, they recommend that until a patient has achieved a GCS score of 15, patient should be observed every half an hour. Okay, patient should be observed every half an hour. And the score range they have given, like if the total score is 15, right, and the least one is 3. If the score is between 13 to 15, it is minor brain injury. If it is between 9 to 12, it is moderate brain injury. And if it is between 3 to 8, it is severe brain injury. If it is 3, that means the patient is completely unresponsive and there are very less chances that the patient is likely to survive, and 0 is the patient is dead. Okay, so these, I hope I answered the question. The next question that you may be asked is about the normal pupil size, or why do we do pupillary assessment. Okay, what are pupils? First of all, pupils are nothing but the black hole that is located in the center of the iris of the eye, which allows the light to strike the retina. Okay, and pupillary assessment, that means where we are checking the size, shape, position and response to the bright light of the pupils, is an important part of neurological assessment. It is an important neurological assessment in comatose patients and patients with brain injury or with brain injury due to multiple etiology. Okay, the normal pupil size in adult is 2 to 4 mm in diameter in bright light, and when it is dark it is 4 to 8 mm. So please remember, the normal pupil size of an adult is 2 to 4 mm in diameter when it is bright light and 4 to 8 mm when it is dark. A fully dilated pupil will be 4 to 8 mm. Okay, fully dilated pupil will be 4 to 8 mm. Okay, then according to the American Academy of Ophthalmology, pupils generally range in size from 2 to 8 mm. Okay, so changes in these pupillary parameters can provide us with important clues to neurological deterioration, elevated intracranial pressure and herniation. Okay, so this is what all about what is a pupil, what is the importance of pupillary assessment, and what is the size of normal pupil size. I hope I answered the question. The next question that may ask you is about the abnormal pupil size. Okay, or they may specifically ask you what is anisocoria. Okay, or we can say when you are doing a pupillary assessment, how do you interpret it? Okay, so when you are doing a pupillary assessment, so you will come across an acronym PERRLA, PERLA. Okay, that stands for pupils are equal, round, reactive to light and accommodation. Okay, so this is what we are going to assess in pupillary assessment. Okay, whether pupils are equal, whether they are round, whether they are reacting to light and accommodating. Okay, so these things we are going to assess in pupillary assessment, and if we find any changes, that shows any underlying pathology. Okay, so here we can see different pupillary responses. Here you can see anisocoria. Okay, the first one that you can see there, the pupils are equal and reacting. The pupils are equal and reacting. Okay, so that is normal. Then next is pinpoint pupils. Pinpoint pupils you will see when in case of opioid, when the opioids are administered, or in case of Pons injury. And unilateral dilation you can see in case of cranial nerve compression, and bilateral dilation you can see in case of injury to the midbrain. And you will come across a term called anisocoria. Okay, anisocoria, as you can see here, it is nothing but unequal pupil size. Okay, unequal pupil size, when the pupils have a difference of more than 1 mm in size, and the cause is brain injury, aneurysm, glaucoma, brain tumor, brain swelling, intracranial hemorrhage, stroke, seizure, etc. Okay, so there are many causes of anisocoria. Okay, so when you are doing a pupillary assessment and you find that the patient is having anisocoria that is unequal pupil size, that means that there is a difference of about more than 1 mm among the two pupils, then it indicates there is an underlying brain injury or aneurysm or brain tumor or brain swelling, etc., etc. Okay, so this is about the pupillary assessment interpretation. I hope I answered the question, and I hope you all are understanding. Okay, so we need to understand, whenever an examiner, not the examiner, the interviewer is asking a question to us, we have to listen to the question properly. Okay, understand it and then answer it, and answer with confidence. Okay, then the next question that they may ask in an ICU nursing interview is about CAUTI. What is CAUTI? Don't be naughty, prevent CAUTI. What is CAUTI? CAUTI is nothing but, as you can see here, it is catheter associated urinary tract infection. Okay, patients having an indwelling or intermittent urinary catheter in the hospital setting, it is very common, especially among the ICU patients. Okay, because they are bedridden, they are on ventilator. Okay, so usually they do have this indwelling catheter. So we need to take care to prevent CAUTI, that is to prevent catheter associated urinary tract infection. And to prevent urinary tract infection, preventing urinary tract infection, it is very important. Okay, so that means what all prophylactic measures we need to take to prevent CAUTI. Okay, because CAUTI, it involves infection of any part of the urinary system. It can infect the urethra, the bladder, the ureter, or the kidneys. Okay, so it's very important for us to take some prophylactic measures, which we are going to discuss now. Okay, to prevent CAUTI. The first one is strict aseptic technique while accessing the catheter. So whenever you are accessing the urinary catheter, make sure that you are following aseptic technique. And the best and the simple way of preventing infections is hand hygiene. Okay, so you have to perform hand hygiene and put on the gloves, okay, whenever you are accessing urinary catheter of the patient. Then the second one will be secure the catheter in the inner aspect of the thigh and label with the date. Why is it important, this step? See, securing the catheter is very important, that too in the inner aspect of the thigh in a butterfly manner. Okay, because if we don't secure the catheter properly, it can be accidentally pulled out. Okay, and because the balloon will be inflated inside, and if it is accidentally pulled out, then it can cause an irreversible damage to the urethra. Okay, so that's the reason we need to be very careful to secure the catheter properly in the inner aspect of the thigh and label with the date, so that we know daily we can assess the necessity of the catheter and remove it if not required as early as possible. Usually a urinary catheter can be retained from 2 weeks to till 12 weeks, okay, depending on the necessity of the patient. Okay, but always try to consider early removal if not required. Then the third measure that we need to take to prevent CAUTI is maintain closed drainage system. Okay, maintaining closed drainage system means the urinary catheter is attached to a closed drainage system urometer. Okay, there, so that there is no urinary leakage, no infections to the others, and no infection to the patient. Then next is and it is convenient to travel also. Okay, then the next is place the drainage tube below the bladder and above the floor. See, the drainage of the urine is totally dependent on the gravity, so that's the reason the drainage tube should be placed below the bladder and above the floor, so that the urine which is flowing from the urinary bladder, it goes directly into the urometer, not back into the urinary bladder, which can cause ascending infection. Okay, then the next measure that we need to take to prevent CAUTI is perineal care. Okay, perineal care, there are certain steps of perineal care, it differs in male and female. Okay, so perineal care should be provided to prevent infection. Okay, and very important that we have to daily assess the necessity of keeping the catheter. Okay, and empty the drainage bag whenever it is full, and document whatever CAUTI precautions we are taking. Okay, so this is how we prevent CAUTI. Okay, so this is CAUTI bundle. So usually they will ask you about what are the care bundles. Okay, the 3 different care bundles that we usually come across is the CAUTI, CLABSI and the VAP. Okay, so we must know about this when we are working in an ICU. Hope I answered the question. Then the next question that they may ask you is about what is CLABSI. Okay, CLABSI, what is CLABSI? Central line bundle. Okay, CLABSI stands for central line associated bloodstream infections. Okay, I repeat, CLABSI stands for central line associated bloodstream infection. Okay, so central lines are very common again in ICU patients. Okay, usually for when the patient requires long-term antibiotic treatment, parenteral nutrition, frequent blood draws, and when the peripheral route is not possible, usually they go for the central lines. And when the patient is when the central line is placed to a patient, then we need to follow certain prophylactic measures to prevent central line associated bloodstream infection, because it is a line which is placed in the main blood vessel very near to the heart. Okay, so what are the measures that we need to follow to prevent CLABSI, that is central line associated bloodstream infection? One is strict aseptic technique before access to the central line. Okay, this is a very important step. For whenever you are accessing the central line, you have to follow strict aseptic technique. That means you have to do hand hygiene and wear gloves. Okay, then next is dressing should be changed and date and time should be placed on it when soiled and infection signs. Okay, so whenever you see that the dressing is soiled over the central line, you should change it, and if there are any signs of infection, that must be notified to the physician and clean and change the dressing. Then next is clean the ports with chlorhexidine 2% and 70% alcohol swabs. Okay, before giving any medication or before accessing the ports, you must clean them with chlorhexidine. Okay, then next is change the IV bags every 24 hours. Then next is daily review of necessity and early removal, because central lines they are very much larger than the peripheral IV lines, and they go all the way up to the vein near the heart. Okay, through the neck or the upper chest or the groin, whatever location you select. Okay, so they are going into the main vein near to the heart. So that's the reason we have to take precautions and follow very strict aseptic technique to prevent central line associated bloodstream infection. So these are the parameters. So if they ask you what is central line bundle or how to prevent CLABSI, then you have to tell about these measures. I hope I answered the question. The next question that you may come across is regarding what are the different types of central lines. Okay, so usually we come across these different types of central lines. Okay, and we should know how to identify them. Okay, and we have to be very careful with them. That means we have to follow very strict aseptic technique. So what are the different central lines? One is PICC line. Okay, PIC line. PIC stands for peripherally inserted central catheter. Okay, as you can see here on the screen, this line is placed in a large vein in the upper arm or near the bend of the elbow, and it is guided into a large vein above the right side of the heart called superior vena cava. Okay, and this line is placed for IV fluids, for giving large amounts of IV fluids, for nutrition, or when they have to frequently draw the blood samples, for blood transfusion, for chemotherapy, and also for administering some other IV drugs. And this PIC line, it is not like the peripheral line which should be removed in 72 hours, 3 hours. It can be kept for about 3 months or more. Okay, but regular checks are needed. Okay, so this is PIC line, that is peripherally inserted central line. Okay, then the next type of central line that we usually come across is this one. This is internal jugular line. What is this? Internal jugular line, IJV we called it as. Okay, it leads into the subclavian vein under the collarbones, and it is the direct continuity with the right atrium. So IJV and EJV are the main path for the deoxygenated blood from the cranium back to the heart. Okay, so this is also very common type of central line that you may come across, that is IJV, internal jugular line. Okay, then next is subclavian line. Okay, the needle is inserted approximately about 2 to 3 centimeter inferior to the midpoint of the clavicle. Okay, and it is the most commonly used line in case of emergency. Okay, in case of acute care access, for chemotherapy, for prolonged antimicrobial therapy, and for parenteral nutrition. Okay, so this is subclavian line. Then one more line that we come across is the femoral line. Okay, which is placed in the here in the groin region. Okay, which is placed in the large femoral vein in the groin region. Okay, and it is preferred for coagulopathy patient. Why? Because unlike the subclavian and the interjugular sides, the femoral triangle, it is readily compressible and it is away from the vital structures. Like, see, if you can see in the subclavian line and in the jugular line, they are very close to the vital structures like the airway, mediastinum, blood vessels to the brain, etc. So if there is a heavy bleeding, we cannot press it there for a long time, as it can cause damage to the vital organs. Whereas this femoral line, it is away from the vital organs, as well as it can be readily compressible. Okay, so it is a preferred site in case of coagulopathy patients. Okay, so this is femoral line. So what are the 4 types of central lines that we come across? Okay, one is PIC line, that is peripherally inserted central line. Next is internal jugular line. Next is subclavian line, and the last one is femoral line. Okay, so these are the 4 different types of central lines that we usually come across. I hope I answered the questions. Then the next question that they may ask you is about what is VAP bundle. VAP, that is ventilator associated pneumonia. Okay, or ventilator associated events also we can say. Okay, so what is VAP bundle and how to prevent it? Okay, so what are the measures that include in VAP bundle? When the patient is on ventilator, we need to take certain measures to prevent ventilator associated pneumonia. What are those measures? What are those prophylactic measures? As you can see here, we need to elevate the head end, okay, to 30 to 45 degree. Why? To reduce esophageal reflux, to reduce pulmonary aspiration, and to prevent ventilator associated events. Okay, then next is chlorhexidine mouthwash to prevent dental plaque or halitosis. That means we have to give daily oral care to the patient with chlorhexidine. Then next is subglottis suctioning to clear the airway. Means whenever it is indicated, we need to do suctioning so that we can keep the airway patent and clear. Okay. Then next is DVT prophylaxis. Okay, as you can see here, DVT prophylaxis to prevent deep vein thrombosis. Within 24 hours of start of mechanical ventilation, we need to start with the DVT prophylaxis also. That means the patient is kept either on oral, what we say, anti heparin, oral heparin therapy, or the fragment, or they will put them on the pneumatic or graduated compression stockings. Okay, so to prevent deep vein thrombosis. Then next is peptic ulcer prophylaxis. That means we need to administer what we say PPI, that is proton pump inhibitor or H2 receptors, to the patient to prevent stress ulcers or peptic ulcers. Then next, weaning of sedation. Okay, so daily arousal is necessary. Daily arousal trials with the period of with a period of time during which the patient breathes with minimum assistance from the ventilator. That is, spontaneous breathing trial should be done, and as the patient improves, the sedation will be reduced, allowing the patient to start breathing on their own. Okay, and we need to check for weaning. Okay, so this is VAP bundle, that is ventilator associated pneumonia bundle. So these are the set of interventions that are taken to prevent ventilator associated pneumonia. So if they ask you what is VAP bundle, you must tell. So as an ICU nurse, we must know about these 4 bundles to prevent what we say hospital acquired infections. One is CAUTI, that is catheter associated urinary tract infection. Next is CLABSI bundle or the central line bundle, that is central line associated bloodstream infection. Next is VAP, that is ventilator associated pneumonia or ventilator associated events, or SSI, that is surgical site infection prevention. I hope you all are finding the content helpful and easy to understand and relevant. Then please keep watching. Okay, the next question that you may face in an ICU nursing interview is about the modes of ventilation. Very common question. I myself was asked many a times. Okay, so what are the ventilator modes? Ventilator modes are nothing but when the patient is on mechanical breaths, okay, or when the mechanical breaths are provided to the patient, whether they should be partial or full, and what should be the breathing pattern. Okay, that is all about the modes of the ventilation. Okay, so there are volume control mode. Okay, in that you have controlled mechanical ventilation, that is CMV, or assist control ventilation, that is ACV, or synchronized intermittent mandatory ventilation, that is SIMV mode. Okay, and the next one is pressure control mode. So you have volume control, pressure control, volume and pressure control, that is the dual control. Okay, in pressure control you have pressure control ventilation, PCV, then pressure support ventilation, that is PSV, or continuous positive airway pressure, that is CPAP. Okay, and in dual control, that is volume and pressure control, you have pressure support SIMV mode. So these are the different basic modes of mechanical ventilation. I hope I answered the question. Next question that they may ask you is about what is FiO2. FiO2, which stands for fraction of inspired oxygen. That means the concentration of oxygen in the gas mixture. That means the FiO2 of the room air, or not only the room air, in air throughout the breathable atmosphere, it is 21%. Okay, and we have a formula for calculating the non-invasive FiO2 calculation, that is 4 into O2 in liters plus 21%. Okay, FiO2 and PEEP are very closely related. Okay, so that's why they may ask you what is FiO2 and what is PEEP, and what is the relation between them, or how they are helpful in oxygenation. Okay, so what is FiO2 we got, right? So FiO2 is nothing but the fraction of inspired oxygen, that is the concentration of oxygen in the gas mixture. Okay, which is 21%. Then next they may ask what is PEEP. PEEP stands for positive end expiratory pressure. Positive end expiratory pressure. It is a pressure that will remain in the airways at the end of the respiratory cycle. That means at the end of the exhalation, that is greater than the atmospheric pressure in the mechanically ventilated patient. Okay, so PEEP and FiO2, they work together to improve oxygenation. Okay, PEEP and FiO2, they work together to improve oxygenation. I hope I answered the question. The next question that they may ask you is about what is unplanned extubation. See, intubation is putting the tube, endotracheal tube into the trachea. Extubation is removing the endotracheal tube or weaning. Okay, so extubation is planned and unplanned. Planned is when the patient's condition is improving and when you see that the patient can stay then on the room air or without the support of ventilator, then you extubate the patient. Unplanned extubation is it is one of the major complications which may occur when the patients are experiencing invasive mechanical ventilation in the ICU. In this, it can be because of two reasons. One is accidental extubation or it can be self-extubation. Accidental extubation means it is caused by the involuntarily by the health professionals during their bedside activities. Okay, or during the transport when we are transporting the patient interdepartmental shift, okay, from, for example, from emergency to ICU or from one ICU to other ICU or from one hospital to other hospital. Okay, so when we are transporting the patient or when we are performing the bedside activities like giving oral care or changing the what we say the bandage which we have used to secure the tube, okay, or when we are giving back care to the patient or when we are shifting the patient from one bed to other bed. Okay, so during while performing all these bedside activities or during transportation, when the patient tube is accidentally extubated or it comes out, that is called accidental extubation. And self extubation means it is a deliberate removal of the endotracheal tube by the patient himself. Okay, and this can happen because when the patient is agitated or when the sedation is not enough or when the patient is in delirium or when the restraints are not properly placed. Okay, so unplanned extubation, it is really very it's really not good. Okay, so we have to take all the measures to prevent unplanned extubation, that is accidental extubation as well as self extubation. And for this you should secure the tube properly, okay, and regularly check for its position and ensure appropriate analgesia, sedation and delirium management and restrain the patient properly. Okay, so it is very important. Fine, so this also they may ask. And next is they may ask you how will you respond to accidental extubation. For example, if the patient has accidentally the endotracheal tube has come out when you are providing care to the patient, or the patient himself has pulled out the endotracheal tube, then how will you respond? What will you do? So what we have to do is attend to the patient's life threats using ABC approach. Okay, that is airway, breathing and circulation. And many patients usually they do not require reintubation. So if oxygenation and ventilation remains adequate, then we can consider oxygen via nasal prongs or mask or high flow nasal prongs or non-invasive ventilation. And corticosteroid treatment can be given with nebulizer. And in case of discomfort, we have to increase analgesia and sedation and call for assistance if likely if there is a difficult airway for intubation. And if stridor is present, then the patient may need a smaller tube. Okay, so when in case of self extubation or accidental extubation, these are the things that we need to do. Do not get panicked. Okay, so relax and do carry out all the steps and call for assistance. Okay, and call for help. I hope I answered the question. Then the next very important and the basic ICU nursing interview question is what are the commonly used drugs for sedation in ICU? Okay, as we know that sedatives are commonly used in the ICU for those patients who are on ventilator. Okay, so those are like benzodiazepine, midazolam, lorazepam, barbiturates, ketamine, tranquilizers, haloperidol. Okay, and propofol is extensively used in ICU actually as sedative. Okay, and dexmedetomidine. Okay, these are short acting IV sedatives. Okay, and fentanyl, morphine, these are also used, opioid analgesics. So these are the commonly used drugs for sedation in ICU. I repeat, benzodiazepines, midazolam, lorazepam, ketamine, tranquilizers, haloperidol, propofol. Okay, fentanyl, morphine is also used. So these are the commonly used drugs for sedation in ICU. Then next is they may ask you about the what they may ask you about what is RASS scale, that is RASS, which stands for Richmond Agitation Sedation Scale. I repeat, Richmond Agitation Sedation Scale, that is RASS scale. It is a medical scale which is validated and reliable method to assess the patient's level of agitation, sedation in the ICU. Okay, it is a 10-point scale where you have 0 there, and then from -1 to -5 points and 1 to 4 points. So 4 indicates, as you can see here, 4 indicates combative, 3 indicates very agitated, 2 means agitated, 1 means restless, and 0 means alert and calm. Okay, and -1 means drowsy, -2 means light sedation, -3 means moderate sedation, -4 means deep sedation, and -5 means unarousable. Okay, so this is RASS scale, which is commonly used to assess the level of agitation and sedation in ICU. I hope I answered the question. Then the last very important and basic question that we are going to discuss in this ICU nursing interview series is, what is the order of sample draw? Okay, so when you have to draw blood sample from a patient, okay, and there are multiple tests mentioned, so which one will you collect first? Okay, which one you will go for last? So there is an order. You cannot collect as you wish like. There is an order in which we have to collect the sample. Okay, so when there are group of tests ordered, then this is the order that we have to follow to draw the blood. First one, you will go for the blood culture. Okay, and in that also first aerobic bottle, and then you will go for the anaerobic. Then you will collect the sample in the blue tube, blue acutainer tube, which contains sodium citrate, and then in the red tube, which contains clot activator, and then in the gold or the yellow tube, which contains SST, and then in the green tube, which contains heparin, and then in the lavender tube, which is an EDTA tube. Okay, and lastly in the grey tube, that is sodium fluoride tube. Okay, so this is the order of blood draw when multiple tests are advised. Okay, and for pediatrics we need 4 ml of blood for cultures, and for adults we need about 7 to 10 ml of blood for cultures. Okay, so this is the order of blood draw for multiple tests. So I hope that you found this video helpful, okay, and the content interesting in preparing for an ICU nursing interview. So all the best for your interview. So please listen to the question properly, understand it, and then answer with confidence. Okay, all the very best. Hope you get selected, and to get more like this interesting content which is easy to understand, simple and logical, please subscribe my channel Nurses the Heart of Healthcare, and stay tuned with me. Thanks for watching. All the best. Keep smiling and stay healthy.